Next section is aortic dissection and aneurysm. We're going to start with dissection and then work our way to aneurysm. So in an aortic dissection, the idea is that you've got this blood vessel wall which contains an intima, a media, and an adventitia. And of course the blood would be flowing up through this wall. Now as the blood flows through the wall, there's a tear in the intima. The blood then goes through the intima, which is of course super thin, and then gets access to the media and begins to rip across the media, dissecting the wall of the blood vessel. And so that's an aortic dissection. Here's a picture of the aortic dissection, and again the same notion, blood is sort of running along this vascular channel, and for some reason there's a little tear in the intima. That then allows blood access to the media. It rips through the media and begins to go through the wall. So this is an example here of blood ripping through the media of the blood vessel wall. Now it's important to note that you don't get a dissection unless you have two things. So an aortic dissection requires two things, and this is really the summary of the entire disease. First of all, you need a ton of stress. You're not going to be able to normally rip through the media of the wall unless you have a lot of stress present within that bloodstream. And so it usually occurs within the proximal 10 centimeters of the aorta. That's right off the origin of the heart, so it's coming directly from the heart. It's got a ton of pressure associated with it, and it's at that point, within that first 10 centimeters of the aorta, that you're going to find an aortic dissection. So that's principle number one. Principle number two is that you're not going to get a dissection even within the first proximal 10 centimeters unless you have pre-existing weakness of the media. This is very important. You must have pre-existing weakness of the media. So then the discussion arises, how could you get pre-existing weakness of the media? And if you understand this, then you understand the causes of aortic dissection. The most common way by which we can get pre-existing weakness of the media would be hypertension. Now what's the idea here? Let's take a blood vessel and remind ourselves that we have an intima, a media, and an adventitia. Now it so happens that the intima, media, and adventitia all contain cells that are living, and therefore these cells of the intima, media, and adventitia also require oxygen. Now they happen to be lucky enough to be carrying blood, so the oxygen that's sort of running through the blood will also be able to diffuse and will be able to feed the intima, the media, and the adventitia. And that's the normal way by which the blood vessels remain alive and healthy. However, in the proximal first 10 centimeters of the aorta, you know that the wall is super thick. So very early on in the aorta, in the very proximal part of the aorta, as it comes off the heart, the wall is very thick, and the diffusion of oxygen across that wall is not sufficient to be able to feed the entire wall. And so in the adventitia here, if you go back to normal histology, in the very thick-walled blood vessels, we've got something called vasa vasorum. So vasa vasorum are these tiny blood vessels that provide blood to the outer aspect or the outer half of the blood vessel wall. Now what happens in a patient with hypertension is that they're going to get hypertension, and hypertension results in hyaline arteriolosclerosis. Remember that discussion? And so that high blood pressure will result in hyaline arteriolosclerosis of these vasa vasorum. That would decrease the caliber of the lumen, which would decrease the amount of blood flow going through them, and so now you're going to get decreased blood flow to the outer half of this blood vessel wall. That's then going to result in atrophy of the smooth muscle out here, which will result in weakening of the media so that a dissection can occur. So that's a very high yield association, and that's the easiest way to understand why hypertension is the most common cause of an aortic dissection. The other way by which you can get weakness of the media would be to have an inherited defect of connective tissue. Remember that the media contains a lot of elastic tissue, especially in that initial portion of the aorta that comes off the heart. And so if a patient has a defect of fibrillin, which is also called Marfan syndrome, remember that fibrillin is the molecule upon which elastic fibers are laid down. And so if there's disruption of elastic, then there would be weakening of the media. In addition, a disorder called Ehlers-Danlos syndrome, in which patients have defective formation of collagen, can also result in weakening of the media. So again, you need to have weakening of the media before this dissection will occur. When patients get a dissection, they present with sharp tearing chest pain that radiates to the back. The major complication of aortic dissection is pericardial tamponade. This is the most common cause of death, but you can also get rupture with fatal hemorrhage, and you can also get obstruction of arteries that are branching off the aorta. For example, let's say that this is the heart, okay, and we've got this proximal 10 centimeters coming off the heart, and then let's say that blood is flowing through here, and all of a sudden we get a dissection. Now when we get a dissection, blood's going to go into the media, and then it's going to dissect through the media. So there's a couple possibilities. It can dissect through the media, and then it can go down, all right? And as it goes down, imagine if eventually we've got the renal arteries coming off here, it can compress and push down on the renal artery, which would then, of course, create obstruction, and then end organ ischemia to the kidney as one example, all right? Another possibility would be that we get this dissection, and then the dissection goes backward, and when it goes backward, it can get access to the pericardium, and so we can get filling of blood in the pericardium, which would be called pericardial tamponade, and that's the most common cause of death. And the third possibility would be to simply rupture out into the mediastinum. And if we blew through the entire blood vessel and then ruptured out into the mediastinum, that would result in fatal hemorrhage. So these are the complications of aortic dissection. The next discussion that we want to have concerns aneurysms. And before we even get to aneurysm, you just need to know a couple basic principles and everything is downhill. So first of all, the first principle is, what is an aneurysm? An aneurysm is a balloon-like dilatation of a blood vessel wall. So here's a normal blood vessel, and we've got this balloon-like dilatation of the blood vessel wall. So that is an aneurysm. That's point number one. Now, aneurysms can occur for classically two places. You can get it in the thorax, and you can get it in the abdomen. So you can have a thoracic aneurysm, or you can have an abdominal aortic aneurysm. Those are the two classic locations in the large blood vessels. Now, what you need to know in order to understand how these might occur is that the only way you're going to get an aneurysm is you need weakness in the aorta wall. You must have weakness in the wall. It's the weakness in the wall that allows this balloon-like dilatation to form. In the case of the thorax, so in the thoracic aneurysm, the way by which you're going to get weakness in the wall is classically seen, or the classic example is tertiary syphilis. Now, what's the idea here? The patient's got tertiary syphilis, and remember that syphilis is an end arteritis. You get inflammation of the small blood vessels. So imagine if this is the intima, this is the media, and this is the adventitia in the thorax. You know that within the thorax, the adventitia contains these vasa vasorum, which are important for feeding and keeping this blood vessel wall healthy. Well, if the patient gets an end arteritis of these vasa vasorum, that's going to decrease the blood flow going through the vasa vasorum, and that's going to then result in atrophy of the wall of the blood vessel, just like we kind of talked about previously. And so when you get atrophy of the wall of the blood vessel, that would make this blood vessel wall weak, and the weakening of the blood vessel wall would then result in an increased risk of getting this balloon-like dilatation, which again would be a thoracic aneurysm. And so in the thoracic aneurysm, the key mechanism by which we weaken the wall is classically tertiary syphilis. That's the classic one. There are others, but that's really the classic high-yield one to be familiar with. Now, when you have tertiary syphilis, one of the classic findings is tree bark appearance of the aorta, and that's because you're getting all of this scarring and fibrosis due to the end arteritis that's occurring due to that tertiary syphilis. And so this is a picture of tree bark appearance, and what I'm trying to highlight, this is the surface of the aorta here, and you can see that there's fibrosis, which is then subsequently giving it a tree bark-like appearance. So what are the complications of a thoracic aneurysm? Well, the most important, perhaps the highest yield, is that you can get dilatation of the aortic valve root. Now here's the idea. If this is the heart, and you've got this aorta coming off of it, all right, if you get a balloon-like dilatation of the thoracic aorta, that's going to pull on this root of the aortic valve. And as it pulls on the root of the aortic valve, that's going to result in aortic insufficiency. And that's the highest yield complication of a thoracic aneurysm. You can also get compression of mediastinal structures. As this thing balloons out, it can compress upon other structures within the mediastinum. And then the third complication would be to get thrombosis or embolism. When you've got a balloon-like dilatation in any blood vessel, remember that normally blood flow is laminar. So you've normally got this laminar blood flow, but when patients get an aneurysm, that results in some disruption of that blood flow, and as you lose the laminar flow of blood, you increase the risk for activation of the coag cascade. So it's not uncommon to get thrombosis along the wall of the aneurysm. Now, of course, if you get thrombosis, the next thing that can happen is this thrombus can eventually embolize, and so that would be the complication of thrombosis. So that's why I say that you can either get thrombosis or embolism. Now, when you think about the abdominal aortic aneurysm, it's very similar. You're going to get a balloon-like dilatation, but instead this time we're in the abdominal aorta. super high yield to know that this is going to occur below the renal arteries, but above the aortic bifurcation. And so here's a picture highlighting that. We are above the aortic bifurcation, but below the renal arteries. And this blood vessel should have normally been like this. However, we've got this balloon-like dilatation to make the blood vessel aneurysmal. All right, so this is a key picture which highlights an abdominal aortic aneurysm. Now the question would be, what makes this wall become weak such that the aneurysm forms? And it occurs due to atherosclerosis. That's the key way by which this wall becomes weak. Let's remind ourselves that you've got an intima, you've got a media, and you've got an adventitia. And when you're way down in the abdominal aorta, remember that their oxygen that's coming from the blood basically feeds the entire thickness of the wall to keep the entire thickness of the wall healthy and alive. Now let's assume that the patient's got atherosclerosis, so they've got thickening of the intima. Now they've thickened that diffusion barrier for oxygen to be able to feed the wall. That's going to result in less oxygen getting to the wall, and so you're going to get atrophy of the wall. And when you get atrophy of the wall, that's going to create weakness within the wall, which will then allow for that balloon-like dilatation to occur. So that's why I say here in your text that it's predominantly due to atherosclerosis. Now, when you think about the classic patient, it's going to be the patient that's got all the risk factors for atherosclerosis. For example, higher incidence in males, higher incidence in smokers, higher incidence in patients greater than the age of 60, and high association with hypertension. So these are all risk factors of patients who develop atherosclerosis. And in fact, one of the most common locations of atherosclerosis in the human body is the abdominal aorta. How do these patients present? They present with a pulsatile abdominal mass that grows with time. As you get an aneurysm, one of the complications of aneurysms is that you've increased the wall stress as you get the aneurysm, and so these aneurysms can over time expand. And as they expand, then the feared complication becomes rupture. So the patients will present with a pulsatile abdominal mass that will grow with time. The major complication, of course, is rupture, especially when it's greater than 5 centimeters. This number is key. Greater than 5 centimeters, there's a very high risk of rupture, and when it ruptures, it will present with a triad of hypotension because they're bleeding, a pulsatile abdominal mass because you'll be able to put your hand on the abdomen and feel that aneurysm, and it'll be pulsatile because blood is flowing through it, and then there'll be flank pain as well. And so these are some of the classic signs and symptoms of a ruptured abdominal aortic aneurysm, which of course is a medical emergency. So that completes this section on aortic dissection and aneurysm.